Moving on, let's talk about Chapter 3, Neurobiology and Pharmacotherapy. We're going to be getting into a little more complicated stuff, a bit of a review for a lot of A&P, and just how complicated the brain is when we talk about maintaining balance and maintaining therapeutic levels of those brain chemicals. In our first case study, let's talk about Eleanor. A political science professor comes to the community clinic complaining of lack of sleep. She speaks slowly, hesitating to think before she answers questions, and her partner, Doreen, who has brought her here, is obviously worried. Eleanor smiles at Doreen. I just need something to help me sleep. I'll be fine. And sleep problems are a major issue you're going to see come up again and again when we start talking about, especially our most common mental illnesses, anxiety and depression. And they'll seek something to help them sleep, but really that's going to be doing more harm than good because we're just masking the problem. And instead of treating the underlying issue of the anxiety and depression, which could then help them get healthy, natural sleep without excessive other sleep medications. The brain is a complex organ, to say the least, and it has a lot of different functions within the body. Everything from maintaining homeostasis, that balance within the body, regulating the autonomic nervous system, hormones, controlling biological drives, behaviors, sleep cycle, wakefulness, those circadian rhythms, conscious mental activity, memory, social skills. And you're going to see a lot come up. Issues with sleep, wakefulness, those circadian rhythms. And I mean, that's always been a problem with mental health care. I also believe technology and those phones are having a major issue and role in further disrupting our circadian rhythms. It used to be just the sun rising and setting. Now we've got that blue light of our phone 24 hours a day. And I believe that's causing a lot more issues than we're aware of right now. One of the base functions of the brain is composed of neurons. And these neurons conduct electrical impulses within the brain to send signals, respond to stimuli, release neurotransmitters. Especially when you start talking about issues with Parkinson's and Alzheimer's and the issues that has within the neurological system. Also, the day-to-day chemicals, dopamine, that impedes the transmission of those electrical signals. There's a lot of different complex interplay going on within the brain, and even just slightly off in one area can have a lot of different issues. The way these neurons communicate with each other, they meet in a gap called the synapse in between two neurons. And the way this communication works is the presynaptic neuron releases that signal across the synapse where it's then received by the postsynaptic neuron to be passed along. These neurotransmitters are also constantly being created and destroyed, much like hemoglobin and other chemicals, hormones, and compounds within the body, that as they age, the body is constantly breaking them down and reuptaking, recycling much of that it needs, and then creating new. And unfortunately, that's where a lot of issues are going to talk about as well. As we get later into the course, we'll start talking about things like serotonin, that happy brain chemical. And as the body releases it, and it's not releasing it at the levels that we need. And that's where you start getting into a lot of your antidepressants as well, such as those SSRIs, selective serotonin reuptake inhibitors, and things of that nature. Audience response question. We know that Eleanor has come to the clinic for help with sleep. Which function of the brain controls this? Would that be A, homeostasis, B, the autonomic nervous system regulation, C, circadian rhythm, or D, impulse conduction? The answer is C. Circadian rhythms are the fluctuation of various physiologic and behavioral patterns over that 24-hour sleep cycle. Changes in sleep, body temperature, secretion of hormones like corticotropin and cortisol, and the secretion of neurotransmitters such as norepinephrine and serotonin are influenced by these rhythms. The homeostasis or balance of these hormones and neurotransmitters is the coordinating and directing of the body's response to both internal and external changes. Autonomic nervous system regulation refers to the control of communication between the brain and cardiac muscle, smooth muscle, and glands, which the internal organs are composed of. Think of your autonomic nervous system as controlling those things you don't necessarily think about. Your heart rate, your breathing. You can breathe automatically, but do you really think about your breathing all the time? Same thing with blinking. these automatic functions of the body. You don't think about your kidneys filtering blood. The kidneys just do it. They run automatically through that autonomic nervous system. There are many different sections of the brain constantly working together in parallel. One of these major areas, the brainstem, controlling breathing and heart rate. The hypothalamus, controlling things like body temperature, hunger, sex drive, sleep. The cerebellum, controlling things like memory, learning, social interactions, and emotions. And finally, the cerebrum, controlling things like motor control, language, hearing, vision, other sensory organs. The brainstem and hypothalamus. These are the core. They regulate the internal organs, the vital functions. And that hypothalamus controls those basic drives and link between thought and emotion and functions of internal organs. And this is a very complicated interplay. Think of the brainstem as that processing center for all of these sensory information, where all of this sensory information is really brought together so the body can make sense of it all and put it together in one clear picture. Located in the back of the skull, we also have the cerebellum and cerebrum. These are very involved in regulating skeletal muscle, maintaining equilibrium, processing those mental activities we talked about, emotions, language, thought, conscious sense of being, memory, and language and communication. There is a lot of different processes going on simultaneously within the brain that all have to work perfectly together in tandem to effectively function in society. Continuing with Eleanor, as the assessment interview progresses and Eleanor demonstrates more slowness and difficulty answering questions, Doreen takes her hand and explains that Eleanor has been having more difficulty with memory lately, both in small things like whether she just ate lunch and in bigger things like what she was in the middle of discussing during a classroom lecture. And unfortunately, when you start having issues in one area of the brain, circadian rhythms, it can have a very snowball effect on things like memory and functioning effectively. All right, another audience response question, and this is a tough one. Which part of the brain is most responsible for Eleanor's difficulty with delivering her lectures and remembering whether she has eaten? Would that be A, the brainstem, B, the cerebrum, C, the cerebellum, or D, the hypothalamus? And that answer would be B, the cerebrum. Again, this is responsible for mental activities, memory, language, and the ability to communicate along with other conscious tasks. Visualizing and identifying physical issues with the brain is obviously difficult. It's not like we can easily crack it open and take a look, see what's going on. But fortunately, they do have a lot of imaging tools that can work. Things like the EEG. We've talked about in MedSurg your ECG, EKG, where you're able to pick up and analyze the electrical signals of the heart. An EEG is much like that, where with electrodes they're actually able to visualize the electrical signals going on within the brain. You also have CTs, MRIs, PET scans, and things of that nature. For our next audience response question, which neuroimaging technique would reveal problems with the anatomical structure of the brain, but not problems in the function? Would that be A, a CT scan, B, a PET scan, C, a SPECT, or D, none of the above? The answer is A. When we start looking at physical anatomical issues, you're either going to be looking at a CT scan or an MRI would be another excellent answer here. There are many different causes of disturbances of mental function, everything from genetics and physical abnormalities to hormonal and imbalanced brain chemical issues, such as norepinephrine, a form of adrenaline, serotonin, that happy brain chemical we talked about, and other neurotransmitters such as dopamine, glutamate, and acetylcholine. And this starts to bring us into our psychiatric medications, these psychotropic medications. And we got to start thinking, what do these drugs do, and how do they do it? What is their mechanism of action? What is the different what are expected response as well as adverse reactions this patient is in danger of? You can also start thinking about pharmacokinetics. If you think about back to your pharmacology course, everything from absorption. Is this a PO medication, a pill being absorbed into the GI tract? Is it an IM medication like the antipsychotic Invega that a patient will get a regular weekly IM injection? How is it distributed? How is it metabolized in the body? And especially excretion. When we start talking about drugs like lithium, lithium's actually processed in the body like a salt. So if a patient drastically increases their salt intake, they'll actually be excreting their lithium out with it. At the same time, if they completely withhold their salt intake, they will not be excreting any lithium as well, potentially raising that drug to a dangerous level. There's a lot of different unique considerations in psychiatric medication that you don't necessarily see in a lot of meds. Also, not to be discounted is pharmacogenetics. Each patient will respond wildly different to these psychiatric medications. While that's going to be true in a lot of drug classes, this is especially true in psychiatric meds. Two drug actions in particular we're going to be discussing are agonists and antagonists. Agonists work to mimic the effects of a neurotransmitter naturally found in the body, to bind and stimulate that neurotransmitter's receptor. An antagonist, on the other end, would block that neurotransmitter's receptor. A great example of this would be in antipsychotic meds. A dopamine agonist, known as a Abilify, would work to stimulate the effects of that chemical within the brain. Whereas an antagonist, a dopamine antagonist, such as Thorazine and Haldol, also very commonly used in schizophrenia, is used to block the effects of dopamine. And while both are used as antipsychotics, they work in two opposite ways to have their desired effects. Another common class of psychiatric medication would be anti-anxiety and hypnotic medications. A major class within this would be benzodiazepines, and it contains a lot of drugs you've probably already heard of. Diazepam, Valium, clonazepam, Klonopin, alprazolam, Xanax, and lorazepam, Ativan. And benzodiazepines promote the activity of GABA by binding to a specific site on the GABA receptors within the brain. This binding results in an increased frequency of chloride channel opening, causing membrane hyperpolarization, which reduces cellular excitation. In more simple terms, they work as a sedative. And they possess anti-anxiety, hypnotic sleep-inducing, also used as anticonvulsants, memory loss medication, muscle relaxant properties. Your two major areas you're going to see this given on the floor is going to be as anti-anxiety and also in the case of seizures, an anticonvulsant in emergent situations. When used for sleep, we would use benzodiazepines as drugs such as Restorol is one you'll see commonly given. Other areas that we haven't discussed yet would be an alcohol withdrawal. Alcohol withdrawal can be a potentially deadly complication. There are some people that have been severe alcoholics for a long, long time, and that sudden withdrawal of alcohol could be potentially deadly. In that case, you're going to have a firm, rigid protocol watching those patients very closely, and often using Valium, Ativan, as a sedative to both lower that seizure threshold and help that patient move through their withdrawals. Another class would be short-acting sedative hypnotic sleep agents. And in this one is a lot of drugs you've probably heard of, seen. I know they had a lot of commercials for these drugs. Everything from Ambien, Sonata, Lunesta. Ambien was one of the originals. That was the big player. And then we've got some of these newer ones. Sonata, Lunesta come on the market. Especially with Ambien, it had a major side effect of sleepwalking. The patient is instructed to take it right there before they go to bed and go to sleep. There's been people that claim they've waken up, driven to the store, done their shopping, driven home, don't remember any of it. Woke up in the middle of the night, cooked a full meal, don't remember any of it through sleepwalking on Ambien. Even had, Roseanne Barr claimed that she was sleep tweeting and blamed a lot of offensive tweets on Ambien, saying she did it sleepwalking. And yeah, while there are people that have serious trouble going to sleep, and they swear by these medications, they also have some very scary side effects. Another area would be melatonin receptor agonists. You've probably already heard of melatonin. It's a naturally occurring hormone within the body that helps to stimulate sleep and regulate circadian rhythms and sleep cycles. Well, by acting on that system, we're also able to mimic some of its sedative effects. Drugs such as Reserine, Selinor, or Busbar can be very commonly given. Next, we're going to be talking about treating anxiety disorders with antidepressants. Depression especially is much more common than you'd think within society. There are a lot of people already on antidepressants, and even more that are completely undiagnosed, managing it on their own. The monoamine hypothesis of depression suggests that there's a deficiency of one or more of these neurotransmitters, specifically going to be serotonin and norepinephrine. And there's going to be a lot of different classes that have different effects on these areas, helping to alleviate the depression. Here, we've got a great list here on the next slide. All right, and as we said, there are a lot of different classes of antidepressants out there. The best way to break these down, especially while you're studying, is do it by drug class. Make sure you know some common drugs in each class, and make sure you're aware of the major side effects as well, because there's a lot of unique side effects. They should never drink alcohol on any antidepressant. The first one we'll talk about is SSRIs, selective serotonin reuptake inhibitors. This is probably your most common antidepressant, known for things like Celexa, Lexapro, Prozac, Paxil, Zoloft. And they also have some very serious adverse effects as well. The big thing you need to be watching out for is going to be serotonin syndrome. This is a condition that will result from too high levels of serotonin. We've now blocked the body's uptake to remove serotonin, and we've created a dangerous condition. Have symptoms everything from dry mouth, GI, tremors, muscle rigidity. Another one works on a similar, in the same class, working in a different way, would be SNRIs. That would be serotonin norepinephrine reuptake inhibitors. And that'd be drugs like Cymbalta, Effexor, that again has that major danger of serotonin syndrome. Other ones a little more old school was going to be tricyclic antidepressants. These would be drugs like amitriptyline, tofranil, Pamelor, which I seem to remember coming up a lot in ATI. Make sure you're keeping Pamelor classed in those tricyclic antidepressants. And that have adverse effects like constipation, weight gain, urinary retention, muscle tremors, which you're noticing a common theme of muscle tremors. That's going to be a big thing to be aware of through all of these psych meds. And finally, everyone's favorite is going to be MAOIs, monoamine oxidase inhibitors. And they have a very unique patient teaching and side effect, and that is that the patient needs to avoid foods that contain tyramine. And to do this, you're going to be avoiding foods like aged cheese, cured meat, pickled and fermented foods, pickles, sauerkraut, soy sauce is a big one, and dark chocolate. I seem to remember an ATI question on chocolate malts. And usually the variation of the question is going to be, you have a patient having these 4 options for lunch, and you're going to remove it. There's going to be no pizza, because that has cheese, that has cured meats and pepperoni. You're going to be no sauerkraut. You're going to be no soy sauce. And dark chocolate seems to be one they like to get you on. Also, instant coffee was in there. Normal coffee is fine. It's something about that freeze-dried instant coffee that contains tyramine. The next one we're going to be talking about is mood stabilizers. The real old school one's going to be lithium, that's still out there a lot. And it also has a very unique patient teachings, very unique patient dietary considerations. And that the patients need to maintain a therapeutic level for their lithium. They need to keep it within a very specific range. And unfortunately, that lithium is processed within the body like salt, just like your dietary salt. And so the patients need to be eating a consistent amount of salt every day so that they can maintain their lithium levels. An example of this is you go to the movie theaters, you eat a big bucket of popcorn. What happens? You're suddenly thirsty. Did you suddenly get dehydrated? No, you've raised up your sodium levels, and now your body wants to flush that out. It wants to maintain that normal level of sodium. But while they're flushing out their excess sodium, they're also flushing out their lithium. The opposite end of that is they just stop eating salt at all. The body's not going to be excreting salt, which means they're also not going to be excreting their lithium, causing a toxic level of that lithium to build up within the body. Also, drugs used as mood stabilizers that you commonly wouldn't think would be anticonvulsant medications. Remembering back to your pharmacology course, Depakote, Tegretol, Lamictal. These are all anticonvulsant drugs used for epilepsy, used to prevent seizures. In this case, it also has mood stabilizing effects, used as a mood stabilizer. Now, if you're ever getting a patient history from a patient and they tell you they're on Lamictal, and you ask them when was their last seizure and they look at you funny, they're not using it as an anticonvulsant. They're using it for its mood stabilizer properties. Moving on to antipsychotic medications. This is going to be another one that has a lot of adverse reactions we need to be aware of. These are also going to be a lot of drugs you may have already heard of working out there on the floor. Drugs like Thorazine, which is a very, very old school antipsychotic, not used as much anymore. But in the same first generation would be Haldol, which is a drug that is still very, very commonly given. Next up will be second generation. These would be the newer antipsychotics: Abilify, Latuda, Zyprexa, Invega, Seroquel, Geodon. And these all have this major adverse effects we need to be watching, particularly extrapyramidal symptoms: rigidity, muscle rigidity, tremors, a shuffling gait. And even more specifically within that extrapyramidal symptoms would be a term called tardive dyskinesia. Tardive dyskinesia is going to be specifically face muscles. We're going to be looking at face twitching, irregular eye movements, and a darting tongue. One way I had a student teach me to remember this was getting the tartar sauce off your lips. Tardive dyskinesia. But yeah, big thing, any of these, as soon as you see any hint of adverse reactions on ATI, on your NCLEX, make sure you're holding that medication and notifying the provider, because these are major dangers. You start seeing any muscle abnormalities within your patient while taking any of these medications, make sure you're holding that dose and notifying the provider immediately. Among those first-generational antipsychotic drugs, we talked about Thorazine, Haldol. These work in antagonists to block the receptors for acetylcholine, norepinephrine, histamine. In addition to those extramyramidal effects, they also have side effects such as weight gain, sedation, and I can't stress enough monitoring those muscle abnormalities with extrapyramidal symptoms, tardive dyskinesia. Among those second-generation atypical antipsychotics we talked about, Abilify, Zyprexa, Geodon, Seroquel, they are the newer drugs. They do have fewer extrapyramidal side effects, but that's not to say that they have zero extrapyramidal side effects. Make sure you're still watching for all of those muscle abnormalities that we talked about along with the first generation. Those extrapyramidal symptoms could be a serious indicator of potential dangers down the road, and we really need to be on that early. There are a lot of second-generation atypical antipsychotics. More that we haven't touched on yet: Clozaril, Risperdal. It's going to see a lot given. We talked about Zyprexa, Seroquel, Geodon, Abilify, and that list could go on and on. Not to overwhelm you with all of the second-generation antipsychotics out there on the market, a big one from this list I do want to talk about is Invega. This one you're going to be seeing given more and more these days, and what's unique about it is that it's given as an IM injection. The patient would come in, say, once a month and receive their IM of Invega, and that's really helpful. You got to think which patients are taking these antipsychotics like this, typically schizophrenia, and this takes a lot of the responsibility off the patient. They take that one monthly appointment, and it also makes sure we as the provider know that they're compliant with their medication regimen as well. Medications treating Alzheimer's would also fall under these psychiatric medication class. Real common one's going to be Aricept given out there, same thing with Namenda. And the big thing to keep in mind with Alzheimer's is there's no cure for Alzheimer's. We can slow the progression of Alzheimer's, but we can't reverse it. These drugs work to cholinesterase inhibitors to slow that destruction of acetylcholine and slow the progression of this condition. Remember, we can never reverse it, but these drugs are very effective and have shown a lot of promise for slowing the progression of Alzheimer's and keeping people's grandparents around for that much longer. ADHD meds as well. These are probably a lot of drugs some of you have also heard of. Drugs like Ritalin, Adderall, Strattera, and they work as a stimulant to help mitigate those effects, and for a patient with ADHD, that helps them increase their focus. A big patient side effect we need to be aware of, big patient teaching we need to be aware of, is keep in mind this is a strong stimulant, and dietary, especially for younger children. Make sure they're only taking it in the morning. You'd never take your Adderall at night. Make sure they're having a big breakfast before they take their Adderall. If we're still seeing weight loss, we're still seeing issues with that, you can also think of things such as supplements, those boost supplements. Try and keep their nutrition up. Make sure they're eating. And again, always take it in the morning because you don't want to take a hardcore stimulant at night. And herbal treatments. These are that complementary medicine. There's a lot of people that, rightly so, do not want to take pharmacologic drugs unless they have to. The big one you'd think of here would be St. John's wort. Taking St. John's wort frequently throughout the day supposedly has a lot of antidepressant properties, can work as an antidepressant. There's also a lot of major concerns with that. How does that St. John wort interacting with what medications they're already taking? Many lack adequate safety and efficacy data, lack of regulation by the FDA, may not always contain the active ingredient displayed on the label. A lot of those supplements you see on the shelf, those aren't covered by the FDA. Those are not regulated in the same way as medications. For us as nurses, you don't want to discourage your patient from seeking alternative medicine, but at the same time, we need to make sure we're really documenting what they're taking, we're aware of what they're taking. The provider prescribing those prescriptions needs to be aware of what they're taking, because there could be so many different interactions with those medications, especially St. John's wort, on the antidepressants or other medication they're already on. Wrapping up, Eleanor is treated with a blank, which helps to slow the destruction of acetylcholine. That be a serotonin antagonist, a GABA, a dopamine antagonist, or a cholinesterase inhibitor? Yeah, just as we discussed a couple slides back, the answer is D, that cholinesterase inhibitor. And finally, a patient has decreased circulating levels of GABA. Which health problem is most likely to suggest? Would that be A, Alzheimer's, B, Parkinson's, C, anxiety disorders, or D, insomnia? Yeah, that answer is C, anxiety disorders, going back to the beginning of our chapter. Again, I know there's a lot of information in psychiatric medications. The easiest way to study these is make sure you're just breaking it down by drug class. Make sure you're knowing the major medications within that class, knowing those side effects, knowing those patient teachings, because that's going to be the big area that you're tested on, is knowing these drug classes and knowing these dangers presented to the patient from taking them.